this webinar this morning on this frosty morning here in Toronto. I know you're not all zooming in from Toronto, but I know the rest of the province is pretty chilly too. So really appreciate you joining us. I thought I'd start by telling you just a little bit about Lupus Ontario. We've been around for over 40 years serving the lupus community in Ontario. And our main focuses are support and education. And we have a support and education led by Sandra and her team, who's doing a fabulous job with webinars, podcasts, and getting information on our website for the lupus community. We also focus on research. We're very proud that over the past 30 some years, we've sponsored a fellowship in lupus research for a rheumatologist in training to study at one of the lupus clinics in Ontario. There's actually 5 sort of official lupus clinics in Ontario, in Ottawa, Hamilton, London, and 2 in Toronto, Sick Kids Hospital and Toronto Western. And affiliated with Sick Kids is a transition clinic for young adults between the ages of 18 and 21. And they go to Mount Sinai Hospital, which is just across the street from Sick Kids. So we fund these hospitals. We also focus on public awareness through our newsletter, our website, media interviews when we get a chance. Not always easy to get on the media, but we do our best. And through our monthly newsletter. And another thing that's really important that we're starting to put more focus on is advocacy. And what we've learned is that because everyone on this panel, probably other than arthritis, is dealing with a fairly rare disease, that we all need to work together. And I'm just so pleased that Sandra has organized this session this morning because we do need to work with other organizations. We know that, as Sandra mentioned, many of our lupus patients suffer from multiple diseases, including myself. And it's so important that we share information and that we are able to work together to improve the life of our communities. So with that, I'd like to introduce our speakers. Sandra, have we got all the speakers on board right now?
Okay, I'm still, well, let me just double check. I was still waiting for Jen. She hasn't signed on as yet, but we will introduce her as well and go through, and then we will just start. And then as she join along, I've sent a message just trying to reach her, but we will start. You could introduce them, and then we will start with Danielle as, yes.
All right, great. Okay, thank you. So this morning, we're really pleased to have Jan Nitti, who's the director with the Raynaud Association of America, and Danielle Hogg, who's an occupational therapist with the Arthritis Society, and Dr. Leslie Laing, who's the president of the Sjogren Society of Canada, and Jacqueline Fraser, who's representing the Fibromyalgia group in London. So I really want to thank you 4 ladies for taking the time this morning to chat with us. And we're all looking forward to hearing what your organizations do and any information that you have for lupus patients. So I'm so glad you're here, and I'll turn it over to Danielle to start.
Just a moment, Linda, before Danielle begin, I just want to let everyone know what the format will be today. So as you know, we have 4 guest speakers today. Each of our guest speakers will provide a 15-minute presentation introducing their role and organization. They will then discuss what support, resources, and activities they're offering their members and how our members can get involved. So we're excited to have this great lineup of speakers. And without further ado, I'd like to introduce Danielle with the Arthritis Association. Thank you, Danielle.
Good morning, everyone. Thank you so much for the warm welcome and for inviting us here today to speak with you all. Let me go ahead. I'm going to try to share my presentation. And maybe someone can give me a thumbs up when it's when they can see my slides. I think this is the one I'd like. Can everybody see that? Awesome. Thanks so much,
Yes.
everybody, for the thumbs up here. All right. So I know we're on a tight timeline, so I will try to press forward here. Sorry, I just can't get my slides to move forward. Here we go. It's not a Zoom meeting without a technical issue, eh? Just 1 second.
That's fine, Danielle. Just take your time.
I'm not sure why it's not letting me move my slides. I'm gonna have to maybe shut it down and try it again here. There we go. All right. So for those of you who don't know much about the Arthritis Society, I wanted to do a quick little overview of our organization. Our mission is to invest in cutting edge research, proactive advocacy, and innovative solutions to deliver better health outcomes for people who are affected by arthritis. So there's 3 main kind of branches of our organization, one of which is research, so putting funds into arthritis research to find cures and treatment for those affected with arthritis. So we want to promote positive impact on health outcomes, as well as advocacy. So we want people with or at risk of arthritis to receive timely and effective care. And the last part is coming up with solutions. So we want people with or at risk of having arthritis to be knowledgeable and empowered about their arthritis, to know what they can do on a day-to-day basis to help manage their disease. So I know when I first was introduced to the organization as a student capacity, I did not have a very good understanding about what arthritis was. I just thought it was something you got when you were older. So I wanted to share a little bit about what arthritis was, because it's so much more than what that general understanding is. There are over 6 million Canadians affected by arthritis. That's 20% of the Canadian population. And there are over 100 different forms of arthritis. And there are 2 major categories, or main categories. One being systemic inflammatory arthritis, and one being a more degenerative type of arthritis, which we call osteoarthritis. In inflammatory arthritis, we know it's an autoimmune condition where the body attacks its own tissues, specifically the synovium, the joint lining, which causes inflammation. And then when this is left untreated, it can lead to joint damage. So the orange circles in this picture here show the most commonly affected joints in someone with inflammatory arthritis. And it's really important for these people to be on anti-inflammatory disease-modifying medications to control and prevent further joint damage. And we also know that people with inflammatory types of arthritis can also have degenerative type of arthritis, like osteoarthritis. And these joints that are typically affected are outlined here in the blue. So just looking at more of the anatomy of what happens. So arthritis, arth meaning joint, and itis meaning inflammation. So it's inflammation in a joint. When the 2 bones come together, we've got a lining of nice smooth cartilage in between the 2 bones that help to allow the joint to move smoothly and freely without any pain. We have a joint capsule, the synovium, and the synovial fluid that's produced to help lubricate the joint, as well as muscles and tendons that are used to help the joint to move and perform its function. And then we have someone whose joint is affected by arthritis. where the body cannot keep up with the amount of deterioration that's happening in the joint. The cells cannot keep at the same pace as the degeneration in terms of tissue regeneration. And so we're left with thinning and uneven surfaces of cartilage, which can cause inflammation and disrupt the normal function of the joint. The body then identifies this loss of cartilage and starts to form a repair process, laying down extra bone, which could then in itself create problems with extra bone growth called osteophytes that disrupt the normal structure and function of a joint. So that's just a very basic, simplified explanation of what arthritis is. And now I just wanted to move into a little bit about what we can do and what resources we offer to help people with arthritis. First of which I want to direct you to our Arthritis Society website, arthritis.ca. It's an extensive website with information about arthritis research, some of our advocacy initiatives. So for example, right now working with trying to get more operation time for joint replacement surgeries, because that's a huge problem across the country. And there's also a large section to help you live with your arthritis. And it's reliable source of information for seeking treatment options in Canada. So the Arthritis Society website has online learning modules and a number of popular topics such as medical cannabis and arthritis, managing chronic pain, overcoming fatigue, and eating well. So these are just some of the resources where you can find out the latest and greatest information on these topics. There's lots of good tips and tricks to take away if you haven't done so already and you think you could benefit from something like this. Taking a look at our website, they've really worked hard over the past 5 years or so, making it really user-friendly so people can get on there and use it quite easily. And then when we look at the solutions portion of our organization, we have something called the Arthritis Rehabilitation and Education Program. So this is kind of like therapy for people with arthritis. So we focus on education and support to help people learn how to self-manage their arthritis. We are funded by the Ontario LIN, Local Health Integration Network, and we consist of occupational therapists, physical therapists, and social workers. We do have a program that we offer to other regulated healthcare professionals, and it's called the Clinical Practice Skills for Inflammatory Arthritis Program, again, to help provide skills for other clinicians to learn more about what people can do when they have arthritis. And we also have a program called Advanced Clinical Practitioner in Arthritis Care, our ACPAC therapist, who again have a lot more specialized skills in arthritis care. Our program offers individual consultations via the telephone. We do video e-visits through OTN and Zoom, as well as in-person appointments. The educational virtual workshops are run through Zoom. They are evidence-based self-management strategies that are presented. And it's also a great opportunity for patient interaction. So not only do we present on what the evidence is saying is helpful for these specific topics, but I think it's a great learning opportunity for people to not feel isolated and alone in their journey, that other people have similar challenges that they're walking through. And I think it really is a great way to get support and connect with other people as well. It is free of charge, and you just have to pre-register in advance through our website at arthritis.ca/events. One of the groups that's offered is the Stay Active with Hip or Knee Osteoarthritis. So really, really common type of arthritis to be affected. There are 3-hour sessions that are offered several times per month, and the strategies are reviewed, such as therapeutic exercise, physical activity, weight management, and community and online resources. So incredibly valuable information there. We also offer one called Taking Charge of Your Inflammatory Arthritis. It's for patients with obviously inflammatory based types of arthritis, such as rheumatoid arthritis and psoriatic arthritis. It's a 3-session group. In this one specifically, we learn more about inflammatory arthritis, strategies to manage symptoms, how to deal with social and emotional impacts of arthritis, and the importance of physical activity, exercise, joint protection, healthy eating, and online resources. And anybody with arthritis can go ahead and register for themselves through our website. There's a calendar that outlines all the events that's offered in the next year, so you can kind of find a time that's convenient and works for you. And these are just a summary of all the different kind of topics that we offer. So arthritis of the hand, spine, foot, sleep better with arthritis, mindfulness and meditation. We do reach out to the hypermobility and EDS population, fibromyalgia, as well as living with spondyloarthritis. Another great resource through our website is the Arthritis Talks webinars. It's a panel of rheumatologists, so they are specialists in arthritis care, and they talk about kind of hot topics in arthritis care, as well as the latest research. So some of the things that they're working on right now are medical cannabis, the research on COVID-19 and its effect in the arthritis population, and much, much more. So in terms of being eligible for our program, you do have to have a valid Ontario health card. And the only fee that is required is if you're in need of a custom splint or an over-the-counter splint or other equipment that you might take advantage of. You can be referred by a healthcare professional through an eFax or the Ocean platform, as well as you can self-refer if you have a confirmed or suspected diagnosis of arthritis, and arthritis being the primary presenting problem. And you can call through our 1-800 number, 1-800-321-1433, extension 3307, to book an appointment. And referrals are triage based on diagnosis, the referral. We do prioritize inflammatory types of arthritis as well as kids with arthritis. People with osteoarthritis are often sent to the group platform first to kind of get the general information. And then if an individualized assessment is necessary, we offer that kind of after they've attended that. And then the same thing, like if people have a diagnosis of fibromyalgia and want to take advantage of our services, we often direct them to the group platform to learn the kind of background information, and then are also offered a one-on-one appointment. So I just wanted to, Sandra, cut me off if I'm going over my time, but give you a brief case study just to give you guys a good idea of what sorts of things we do when you come to see us. So we're looking at somebody who comes to see us that has some osteoarthritis in their knees. So we do a history. We look at the summary of how the arthritis started and how it's been progressing, and how it has been interfering with activities of daily living. We look at what medication they're taking, what other health issues they may have, as this may give us some insight into a reason for a flare. Are they taking their medications properly? Are they taking them at all? And is the doctor aware? From a physical exam, we ask them more specifically what they're struggling with and what strategies they already have in place. So we look at the way that people are walking, what their alignment is like. We look at joint range of motion, strength, as well as functional tasks such as transfers, squats, and balance tests. And then we want to start with education as far as treatment goes. So we want people to understand, what is arthritis? What does it mean? What kind of symptoms it causes? The background of how it causes certain symptoms. reviewing medications and supplements and diet related to arthritis. We look at joint protection, so what footwear are people wearing? Is weight loss a goal of theirs? Activity modification, so any activity that can be made easier and less straining on the joints. We look at fitting and teaching people how to use canes and walkers, recommending certain equipment such as grab bars, tall toilets, as well as railings. For pain management, we might look at things like joint protection, heat versus cold therapies, as well as different splints or bracing options. And then we look at what the research says in terms of exercise for the knee. So this is a GLAD. We base a lot of our exercise recommendations off of, for hip and knee arthritis, off of a study called GLAD. It's the Good Life with Osteoarthritis in Denmark. It's an evidence-based education supervised neuromuscular exercise program delivered by a physiotherapist. What the evidence is looking at is 2 hours of strengthening per week can significantly reduce pain and improve function. So we help teach people how to do exercises in this form because we know that the research says it's really helpful for symptom management. So just a little summary here in that it reduced improved physical function and activity, reduced the use of pain medications and sick leaves. So it just improved quality of life, which is huge. Other exercises that are recommended: low impact exercise, swimming, cycling. We know that's really, really good for people with weight bearing joint issues. Walking poles can reduce strain on the joints on the knees by 10 to 20%. And then we also want to, we have therapists all across Ontario, and we look at what local resources can they take advantage of as well. So we help them navigate what's around them locally that would be helpful. And then with rheumatoid arthritis, this is for a splinting referral, something that we might look at. Same idea in terms of looking at the history, the disease, social aspects. We do a joint count to see what joints are active and involved, what damage and deformities may exist. And then again, providing education about the disease, medications, joint protection, pacing, pain management strategies, such as using some things like this to make life easier for them, less strain on their joints. We look at different splinting options. So some of them are prefabricated if appropriate, and some of them are custom for wrists or little fingers that are involved. And then we also have a huge social work role. So we have multiple social workers on staff to help people with coping, transitioning, grieving, and changing when you receive a diagnosis or going through a really rough patch with their disease. And these are just some of the different things that they can be helped with. So doing a psychosocial assessment, counseling support, assistance with advocating for themselves, employers, other aspects of their life that need support. Also assistance with filling out the tedious paperwork involved in gaining access through disability programs and such, as well as accessible housing. And then obviously the huge emotional impact that arthritis can cause, and working and navigating and supporting people through that. We can't make people, I feel like we can't make people better physically if they're struggling mentally. So it needs to be, both things need to be addressed. And lastly, for those who are unable to access our services in any other way, we a nice feature of our program is that we can offer home visits as well. So just in conclusion, our main goal is to work with people with arthritis as they learn to adapt to living with a chronic illness. So thank you for listening, and I hope that that you've learned a bit more about what our program has to offer, and how you can kind of take advantage of that, because that's probably the biggest complaint we get about our program, is that it's hidden gem. And we really want to spread awareness and spread our reach to help people that are struggling with their arthritis.
Wow, that is a lot, Danielle. Thank you so much. That was excellent information. I myself are one of those people with these multiple autoimmune conditions, because I do have osteoarthritis, and you've got a lot of programs, like you just said. It is a hidden gem, because I'm gonna have to reach out to the Arthritis Society to utilize some of these programs, and just even the education and the support that you're offering is huge. So just for everyone that is on this webinar today, we will request from our guests their presentation, so we can post those on our website as well. So in case you need to refer back to some of the information that Danielle talked about and some of the services that they have to offer, we will have that posted on the Lupus Ontario website. Perhaps, in the next few days, once we have the opportunity to receive those from our guests. So thank you again, Danielle. That was a lot of information. We will have a question and peer session at the end. Today, I would like to just welcome, working alongside me is Martina and Rupinda, and the chat will be monitored by them. So we will go through questions a little later on. So moving forward, that was wonderful, Danielle, and we just really thank you for that. Moving forward, I will invite Dr. Leslie Laing to share the screen and begin her presentation. Welcome, Dr. Leslie.
Thank you so much. It's delightful to be here. I see some familiar names. I can't see your faces, but I recognize some of the names. And what a wonderful event this is. Some of the initiatives I think that Danielle presented are similar ones that I have. Alrighty, so I want to get rid of this little picture. I don't need to see myself. Thank you. There we go. So who am I? So I am the president of the Sjogren Society of Canada. I am a prosthodontist, which is a dental specialist who replaces missing teeth. But my interest in Sjogren's came way back when I was a grad student of immunology. And that was when the autoimmune disorders were first coming on the scene. And it sparked my interest in it. And I must admit that I am extremely passionate about those who have Sjogren's, because I've seen so many patients now and would like to help as much as I can. So our Sjogren Society of Canada was formed in 2006 by our first president, Lee Durden. And it's a national nonprofit organization dedicated to improving the lives of the Sjogren's patients in Canada. Our mission is to provide support and education for both those who are diagnosed already or undiagnosed Sjogren's patients. We want to increase the professional and public awareness and to promote and fund Sjogren's related research. We have a managing director, Lauren Vording, as well as I mentioned, our founder and first president, Lee Durden. We have a board of directors. We also have a medical advisory board, of which we have rheumatologists, optometrists, oral medicine specialists, as well as a dental specialist, me. So we have all kinds of specialists working with us together. So Sjogren's, now the one with the funny name, it's the disease is known as Sjogren's syndrome, Sjogren's disease, or now it's even known as Sjogren's. And yes, it's a very funny, often mispronounced name. And I apologize for any of you who are of Swedish background, but for those of us who speak primarily English, we would pronounce it as Sjogren's. We're kind of happy people, so we want to show grins, right? Okay, so this picture of this handsome gentleman is actually Heinrich Sjogren, who was a Swedish ophthalmologist, and he published his first papers in 1933 on his findings of 19 of his female patients who came to him concerning dry eyes. And in his review of the medical history, found out not only did they have dry eyes, but they also had dry mouth. They had symptoms of arthritis as well as excessive fatigue. It took a long time for this to actually become noticed. In fact, he did not get a seat in his university because it was considered to be inconsequential. But I'm proud to announce that as July 23rd in 2022 will be the 13th annual World Sjogren's Day. So even though that it's been around since 1933, it's only relatively recently that Sjogren's has become internationally recognized. And July 23rd, as you can imagine, was Sjogren's birthday. And we dedicate the month of July to be the Canadian Sjogren's Awareness Month. So we're very delighted to have produced our updated brochure, which you can see pictured there. And just what is Sjogren's? Well, it's one of the most prevalent autoimmune diseases that affects approximately 1% of Canadians, or 430,000 Canadians, 90% of whom are women. The main 4 hallmark symptoms are dry eyes, dry mouth, excessive fatigue, as well as joint pain. But there are actually 64 different symptoms, of which you can also have drooling and also tearing of the eye. So it's very confusing, confounding some of the symptoms. The ways in which Sjogren's can affect your body overall, it's almost any area in the body, from headaches, dryness, altered taste and smell, increased dental decay, going right down to vaginal dryness. Very difficult, sometimes goes unrecognized. It's almost like Harry Potter and his invisibility cloak, because particularly when the patients go to see their doctors and they will say that they're suffering from a dry mouth. Unfortunately, some of the answers are, well, they're there, dear, drink water. Unfortunately, water doesn't cut it. As soon as you drink some water, you'll also swallowing some of the saliva. And most of my patients will say, well, actually, when we drink water, it makes our mouth even drier. So it's a very confusing, confounding disease. So how does the Sjogren Society of Canada work for you? And I'm paraphrasing somebody else's phrase here by saying membership has its benefits. So with respect to patient support, you will have access to an expanding network of local support groups and contact persons. So we have many support groups throughout Canada, and we can certainly, if you're in a certain area, we can let you know where the support group is. When COVID-19 first came on the scenes, not only did we let our patients know what was the information with respect to COVID, but we also learned from many of our patients that they were having trouble getting the medication hydroxychloroquine, especially when one of the presidents of our neighboring country decided that this was going to cure COVID. And many patients told us that they were now having difficulty getting access to their hydroxychloroquine or Plaquenil. So we, as well as some of the members from the other autoimmune disorders, formed a group called SADA, or Stakeholders of Autoimmune Diseases with respect to drug access. And we were able to jointly write a letter to Patty Hajdu, who was the Minister of Health at the time. And through that advocacy for our various patients, we were able to ensure that hydroxychloroquine was now going to be made available to the legacy patients, and that anything new that was going to be coming in would be earmarked for research purposes, but that our legacy patients would not be at a loss in getting their hydroxychloroquine or other medications. We have a list of the Sjogren specialists, because not everyone knows what this is. We maintain the list and make it available to all our members, and it includes a list of rheumatologists across Canada, dentists as well as dental specialists, and also eye specialists, ophthalmologists, or optometrists who are certainly familiar with Sjogren's. We have a quarterly newsletter known as Connections. We have it filled with educational information, whether it's respect from diagnosis to treatment. And I might mention that there have been 13 different criteria since 1965 that keep changing, one of which didn't even include the mouth back in 2012. Fortunately, that has been overcome. But in that Connections letter, we also have information about upcoming events and local walks. In addition to that, we have a monthly e-newsletter that also talks about events and fundraisers, as well as tips for living with Sjogren's. We have a members only virtual town hall events. We've had 3 of these already. We have another one coming up December 6th, I believe it is, all about nutrition. We get, as a member, you get a discount on our national patient conferences, which are usually in April, although in 2020, we had one in the fall of the year just because of COVID, and it was virtual, but you also get a discount on some of our publications. With respect to our advocacy, not only through the help of our board of directors and our medical advisory board, but our Sjogren Society of Canada is committed to monitoring Sjogren's related issues in Canada, encouraging research into Sjogren's, as well as informing patients about new treatments and research updates. So some exciting news from our society. We are about to launch our new revamped website. It'll be in early 2022. One of our main objectives is to better inform our members, Sjogren's patients, as well as the general public about living with Sjogren's. Now I'm going to ask for your help. We would like to have, in 1 or 2 sentences, you to submit your answers to the question, what is an essential survival tip that really helps you live as well as possible with Sjogren's? Once you submit your answers to us, and make it short if you can, please, all entries will be included in a draw for our society prizes, which can include caps, t-shirts, as well as what we call See Me bands, and these are reflective armbands. And we will review the submissions and select the best ones to include on our new website. So this is where you can all help us if we can. More exciting news as well. Our own soon-to-be bestseller. This was written by one of our Sjogren's patients, who also, by the way, happens to have lupus. And it was inspired by, the author is Heather Foisey, and it was inspired by her son, Phoenix, and the book is called I'm the Biggest Helper. And it's a wonderful children's book, not only to explain to them what autoimmune disorders or diseases are, but how they can help. And there's some children's activity in this as well. So stay tuned. This is going to be on the #1 bestseller list. This is how you can get in touch with us. Our main office is in Paris, Ontario, but you can certainly get in touch with us through Lauren Vording, our managing director, and any specific questions, whether it's eye related, mouth related, will get forwarded on to one of our medical board of directors, or myself, if you have any questions about dry mouth. And I specifically will ask you, if you do suffer from dry mouth, the dry mouth that you experience from an autoimmune disorder is completely different than, say, something that you experience from taking one of the between 500 and 1,000 medications that cause dry mouth. The dry mouth from head and neck cancer radiation treatment is completely different again, as well as the dry mouth you get from smoking cannabis, or also called cottonmouth. So here is my Sjogren's email address. That way I know you're talking about Sjogren's. But please feel free to contact me if you have any questions about dry mouth or about Sjogren's in general. So thank you so much for your time and attention.
Thank you so much, Dr. Laing. That was excellent. Again, I'm just so amazed of the information we're getting today. It's going to be so important, I think, moving forward and being able to share these resources with our membership at large. Just one quick question, because I know that will be on everyone else's mind. When is the deadline for this contest that you're running?
Oh, we were still discussing it, but I think if we say by the end of the year.
Okay.
Yeah.
So we can put that out when we send that out. Okay, and when is this book coming out? That looks like very interesting.
It's out already. And,
it's out already. Okay,
it's out already. Yes.
Is just online, or we can, or through all the major sources, we can order it.
Well, certainly you can get it through our own website.
Okay.
But it is going to be available in some stores as well. Yes, and I believe $5 of each sale goes to our society, because every penny that we spend is every penny that we earn from our donations. We don't have funding, unfortunately. I guess we're too invisible.
Oh, well, that looks like a great book, definitely for those, and we'll definitely share that, because, you know, with children, it's always so hard to try just to get that book from a child perspective. It'll be pretty amazing. So good luck with that. And again, another huge thank you for taking your time out on a Saturday morning, as well to everyone who is joining us today. We really appreciate it. So we'll just take a couple of minutes break while Jacqueline set up for her presentation. If you need to take a bathroom break, grab a water, we'll give you a couple of minutes, and then we'll ask Jacqueline to begin. Again, we will have time at the end for some Q&A. So just a couple of minutes and we'll get Jacqueline set up, and then we will continue. Welcome Jacqueline from the Fibromyalgia, and I want to say a special thank you to Jacqueline, because I had actually attended a couple of their events and I was on their mailing list. So when I was thinking of this idea of this discussion, I reached out to Jacqueline, and I, you know, just to give her an idea what I was thinking about, and if that's something she thought her members or herself would be interested in doing. And she was right on board. She gave me some great ideas as well, as far as, you know, the planning of it go. So Jacqueline, a special thank you as well to all our guest panelists. You've all contributed, but she was just, you know, instrumental in giving me the go ahead. Thought it was a great idea. And just without even giving it any thought, she said she would love to be involved with something like this. So Jacqueline, welcome.
I guess I should unmute myself. Thank you.
Okay.
Thank you. Thank you for that very warm welcome. I am genuinely honored to be here today, honored to be included, and delighted to see so many faces that are familiar from the fibromyalgia community, as well as to see so many people from the other communities here, all wanting to educate themselves and to learn more about the resources, which are often the hidden gems in any community, the local resources and the national resources that are available to all of us. We just have to look for them. I'm going to start my presentation here. We're just giving you a very quick sound bite, and I'm timing myself to make sure that I don't go over.
I'll monitor. You just go ahead and you do your
thank
presentation.
So I actually founded Fibromyalgia London. It's one of my proud personal achievements back in 2014. And we're now in our 8th year of operation. Over the past several years, we've ebbed, flowed. Teresa Spence, who's on the call here, was actually a co-leader with me, and we grew it to a point. And unfortunately, she got afflicted with osteoporosis, and so she had to step back. But she is one of the anchors I turn to, and one of my mentors that I turn to as we try to continue doing what we wanted to do for the fibromyalgia community. Because of the pandemic, we were forced into a situation where we knew people needed help. We were listening to people expressing their desperation, their loneliness, their fear of isolation. And so we knew we had to do something about it. So within 2 weeks, the leaders learned how to use Zoom, myself included. And so we've evolved from being an in-person support group that was London-based to a virtual support group for fibromyalgia without borders. Something I and the rest of the leadership team are very proud of, what we've accomplished in the last year and a half. We currently have 130 active members who reside across Canada, from the USA and even UK. Once the COVID pandemic is over, we intend to continue offering both in-person and virtual programming. And we'll figure out how we're going to do that as community spaces. We rely on community spaces to hold our meetings. So stay tuned for when we do go back to in-person. We offer volunteer opportunities to share your gifts, skills, and professional expertise, because it does give you a sense of purpose and belonging. Oh, how do you go to the, yep, sorry, yeah. So what's our purpose and mission? Keep in mind that we are purely volunteer-led, volunteer-managed. And so everything that's done, there's a zero budget to, or rather a zero income in terms of funding from government agencies or governments. And what we are trying to do is provide people with fibromyalgia, regardless of where they live, with access to safe, scent-free, supportive, inclusive spaces, virtually and in person. We encourage their caregivers and loved ones to participate in especially the patient education portions or programs, because it's so important that we remember and that this journey that we're on is not just our journey. It affects our family members and our caregivers. And so we want them to be a second set of eyes and to actually hear from other people living with fibro what it is they're going through. And, you know, in the hopes that they can better understand and empathize and be more compassionate and caring to what the experiences are of people with fibromyalgia. We also want to increase individuals' knowledge and education about this invisible chronic, it's a multi-systemic illness. And we want our members to find inspiration and acceptance in a caring, positive, fun, and friendly environment. And most importantly, we want you, the person with fibro, to develop and strengthen your ability to not just survive with fibro, but to thrive in it. Our shared values is something that helps us shape what we do. We want to engage with people. We want, and I'm not just talking about the leadership team, I'm talking about our members. We want them to be active. We want them to participate in this community we are building. So we encourage you to engage, to advocate when you're out, when you're in the community at large. You go to see your doctors to learn how to become your own advocate. We try to empower our members to support themselves and to support the people in this community. We maintain a safe, inclusive, non-judgmental, caring, positive space. Again, whether it's in person or virtual, we follow that mantra. We also want to encourage you to stay informed on research and development. In other words, take an active role in the illness that you have and the journey that you're on with it. And we also want to serve as a reliable source of information, connections, and links. And we just launched our website back in September, a revamped website. And I'm managing that actually. And we went into a WordPress platform. So it's a work in progress website, and I'm always looking for information from the community to add to it. Our vision is to become a respected peer-led community support group. We want to be recognized as a reliable resource and referral basis for health wellness information on fibro. We are building a strong network of connections for people with fibro and their families, and we strive to raise the level of public awareness and education on fibro. We are also advocates for increased accessibility to community and government funding, resources and services for coping with symptoms. People with fibromyalgia, the number one thing they will tell you is they do not feel heard. They do not feel, they feel overlooked. that government systems, medical bodies overlook just the depth and breadth of this illness and how it is a life-altering, life-changing illness. And we, as an organization, we want to unite people with fibro, not just in London, Ontario and area, but also across Canada, to become a stronger voice for better recognition and validation of our invisible illness. So let me just get into a little bit about what fibromyalgia syndrome is. It used to be known as fibrositis and fibromyositis back in, I would say, the 60s, 70s, 80s, maybe as late as the 90s. It's a disorder, a condition. It's a chronic invisible illness and disability. And its primary or hallmark, to use Dr. Laing's term, hallmark symptom is long-lasting pain and tenderness throughout the body. Muscle stiffness, fatigue, and fatigue is not tiredness. They're two different things. Sleep and cognitive disturbances and emotional and mental distress, such as depression and anxiety. Fibromyalgia is not recognized as an autoimmune disease. Researchers believe that FM amplifies painful sensations by affecting the way our brain and spinal cord process painful and non-painful signals in our brain. So there's a neurological base to it now that's being currently being researched. Fibromyalgia can interfere with one's ability to perform everyday activities, including your job responsibilities. So you'll find a lot of people with fibro, myself included, have had to medically retire from our careers, chosen professions, which in itself is very life-altering and life-changing. It also limits your physical activities and exercise, and it does weaken our body. Most people with fibro are women, but men and children can also have this condition. And the number one fact that people have to keep in mind when they come across people with fibro is not to compare themselves or others, to compare them within, to person A and person B, because everybody's experience with fibro is different. The severity, it varies from mild to severe and can often be debilitating or disabling. Here, just to go over, just like Sjogren's, many of the symptoms that Dr. Laing listed, I could recognize as fibromyalgia symptoms. And so we share some overlap there. But the primary symptoms, now our group went through an exercise where we polled the patients or people within our community for what symptoms they deal with on a daily basis or almost on a daily basis. And we developed 4 pages of symptoms. And that's become a tool that we share with our members, and especially with those who are newly diagnosed. We call it the Fibromyalgia Symptom Inventory List. And many of our members have proven that by taking that to their doctors and using that as an advocacy tool, as a tool to say, I really need you to pay attention to what I'm going through, and and stop brushing my concerns aside. They've used that as a tool of communication and have actually been able to, get their doctors to sit up and pay attention. As I mentioned before, muscular is a big one with us. Myofascial pain, fatigue, we get twitches, we do get numbness and tingling. These are not 24/7, but the pain is 24/7, but the intensity and the variety of the pain is different and in different parts of our bodies. In the central system, we get things that we get as symptoms, headaches, sleep disorders, dizziness, cognitive impairment or memory impairment. You'll hear the term brain fog. Many of us go through that, where we're talking like myself and suddenly might go blank. We also suffer from anxiety, depression, urinary issues with our bladder. In females, we have dysmenorrhea or endometriosis. Endometriosis. They can be triggers to fibromyalgia. We do have vision problems with blurred eyes, it's sometimes it's not, we've been told it's not the eyeballs, it's the muscles in the that control the eyeballs that have the issue, that lead to the issues we have with vision. We also have TMJ, dysfunction in the jaw, skin, allodynia is one of the things where your skin is very sensitive to touch or to things like heat and cold. Chest pain, costochondritis is one of the symptoms or illnesses that are comorbidity with fibro. Stomach, many of us have IBS or GERD. And of course, we go through morning stiffness. And systemically, we have, as I mentioned, chronic pain, weight gain, cold symptoms, so flu-like symptoms, and some of us have multiple chemical sensitivity. What causes fibromyalgia? Well, it's unknown. They're still doing research, and there is presently no cure. Current medical thought is that it's caused by a combination of physical, psychological, and biological factors working together. And it is known that fibromyalgia can be triggered by physical trauma, like a surgery, injury, infection, even giving birth, significant psychological stress, like the breakdown of a relationship, going through a very painful, difficult divorce, separation, the death of a loved one, abuse or trauma that you experienced in your childhood. And there is researched evidence of the following causes: environmental factors, genetics, depression disorders, neurochemical imbalances, and brain abnormalities, which results in altered pain perceptions. They're all contributing factors to triggering fibromyalgia. Very briefly, this was how I was diagnosed back in 2003, 18 tender point examination. But since then, the Association of the ACR, I think it's called American College of Rheumatologists, came up with a new diagnostic criteria that they adopted, then modified in 2011 and 2016. And this is the new way where they look for widespread pain over the 7 days. And they now have, instead of 18 tender points, they use 19 regions. There's a symptom severity scale and a symptom identification that is in the paperwork that you have to fill out. And all reported symptoms must be present for at least 3 months. And when they combine the widespread pain index and the symptom severity scale, the score has to be a maximum score of 31. And this is all based on self-reporting. And that's one of the complications or the challenges with fibro. There's no definitive test that one can run that can accurately, through your DNA or through lab readings, tell you that you have fibromyalgia at this time. So right now, we used to be diagnosed by rheumatologists. That is no longer the case. And currently, and this is a huge challenge for the fibromyalgia population, or people who are looking to find out if that's what they have, we rely on our family doctors for diagnosis and treatment. And I'm sure you're in the other groups, they have individuals who go through this where they're challenged with the doctors that they have, who may not necessarily have a wide understanding or an in-depth understanding of the specific illness that you think you might have, or they just still brush it off as it's all in your head, or treat the symptoms. Don't bother about manage your pain. Don't worry about trying to figure out what it is you have. Those are some of the responses we get. Some facts about fibro: it affects 2 to 4% of Canadians. So that's 760 to 1.5 million Canadians that could have fibromyalgia today. Most people with fibromyalgia, as I mentioned earlier, 80 to 90% are women. But although it is painful and life-altering, fibro does not lead to permanent joint damage or deformity. So it's not a structural issue with your body, a mechanical issue with your body. And people with fibromyalgia, people with chronic illnesses like ME, environmental sensitivities, rheumatoid arthritis, osteoarthritis, lupus, and Sjogren syndrome can all have fibromyalgia. And so when you're diagnosed with fibromyalgia, very often we're faced with the question, now what? Here's a quote I just wanted to share with all of you. Sometimes life doesn't turn out the way you may have wanted it, and chronic illness can alter even the best laid plans, but that shouldn't hold you back from your future. You have a choice. And your new norm is living with in our case, living with fibromyalgia, but you could easily insert Sjogren's in there, or Raynaud's, or even osteoarthritis or rheumatoid arthritis. Chronic, invisible, life-altering illness is what our new norm is, living with that. How do we support our members or people who join us? We have programs and activities, patient education. We do a lot of information sharing. We encourage socialization in our programs. We build up your fibromyalgia survival toolbox with coping strategies, equipment, aids. We offer volunteer opportunities, as I mentioned before, because it gives you purpose, helps you grow, and it provides you the way to give back to your community. And most importantly, we encourage our members to stay informed. I do a lot of email communication and updates, social media announcements, and we frequently update our website. So we encourage everyone to visit our website, once a week, just to check what's there. We currently offer as many as 13 different programs. When you join us as a member, you have access to all these programs for free, and you can join them, and you could decide to leave them. You just have to keep us informed. Registration is required for any of our programs or activities. But we offer, as you can see, a wide variety from yoga to qigong to mindset matters, soul to soul. We even talk about the spiritual aspect of living, knitting. We have many people who have learned how to knit online. And we have social conversations, Chatterbox Arts and Craft, which is run by Heather Whitland-Serslet. She's on the call today, and she's actually someone who has lupus, who shares her passion for art by giving back in this way. And we also have a group games, fun and more, and 3 sharing circles right now that we offer through the month for people who need to talk about their illness and their frustrations, challenges that they face, and to learn from each other, coping techniques. It's a great space to explore new things, to open your mind and heart to new ideas and new ways to look at challenges you're facing, and just a place to decompress and share your frustrations with people who get it. We also have patient education opportunities. I organize monthly health talks. Next week, we're having one on spine and health with a medical radiologist. He's also a neurosurgeon, so he's coming to talk to us, and I'm quite excited about that. He'll be talking on medical imaging and the use of a variety of injections and ways to treat people using medical imaging. We hold resource information seminars, and we had over 40 people attend last week's disability tax credit and RDSP workshop held by 2 people that live in Guelph. We ourselves run a peer-led Fibromyalgia 101, and that's especially helpful for people who are new to the illness, who really are lost and don't know their way and don't know, the long road ahead of them. So we're there to help them out to better understand what is happening and the resources they can tap into. It's not just limited to them. We want their caregivers and loved ones to come, but we also do welcome any member who wants to take it as a refresher course. We accept anyone wanting to participate in that. And we have a clinical social worker who's a certified expressive arts therapist who has fibromyalgia and a brain injury, who shares her expertise. She runs her own organization called Paint It Out, but she's donated her time to us as her way of giving back to her community in fibromyalgia. and she offers, well, she offers a variety of different programs, and they fluctuate through the months. And in December, she'll be holding, because Christmas is near, she's decided that she wants to hold a workshop, a 3-hour workshop on joy and happiness. How does one become a member? As I mentioned, we are peer-led health and wellness group. We pride ourselves in being an inclusive group, so we welcome anybody who lives with a chronic illness or a comorbidity of FM. So anyone on this call today is eligible to be a part of our group. We do charge a membership fee of $15 a year, and we reduced that from $20 pre-COVID. And the last year and a half, we didn't charge anything because we wanted people to access. It was important for us that people in the community, regardless of where they were, who needed help, got the help they needed, or got the connection they needed socially, as well as to deal with aloneness or loneliness. But this is our only source of funding to support our ongoing operational costs. Fibromyalgia is, unlike Lupus and the Arthritis Society, we are not a registered charitable organization. We are still a grassroots non-incorporated organization. That's purely because of the funds needed to become one. So we are unable to provide you with tax deductible receipts. Payments can be made via email, by e-transfer or by check. So very simple steps. Go to our website. You go to the membership page, you scroll down, you'll find the online membership application form. Fill that in, select what programs and activities you wish to participate, how you're going to pay, hit submit. I'll get it and you'll become a member instantly. As part of my communications with the community, I send out a month at a glance. This helps the members, take down or note what they want to participate in for the month. And then I send out Zoom links every week to the different activities that are happening that week. And you use that link to get onto the programs that you want to. You can also check our Twitter, Facebook, Instagram for these resources. And I wanted to leave you with this. I wanted to give you something to reflect and ponder on this weekend, because you have a choice. And this doesn't matter what kind of chronic illness you have. Life is all about how you handle Plan B. Plan A is always my first choice. You know, the one where everything works out to be happily ever after. But more often than not, I find myself dealing with the upside down, inside out version where nothing goes as it should. It's at that point the real test of my character comes in. Do I sink or do I swim? Do I wallow in self-pity or do I play the victim? Or do I shift gears and make the best of the situation? The choice is mine. After all, life is about how you handle Plan B. Thank you.
That is excellent, Jacqueline. Again, some great information from our guest speakers. And again, we will get copies of these presentation. I know there was a lot of information in the Jacqueline presentation regarding, even just the how to get your diagnosis. And I'm glad she shared something like that with us, because I know fibro is a really hard one. So we will get that information from her. That will be on our site, so you can go back and use it for your reference later on. So thank you again, Jacqueline.
You're welcome.
So at this time, we would like to welcome Jan Nitti. She's actually all the way from the USA. So we really thank you. I know it is your Thanksgiving weekend, Jan Nitti, and we do appreciate you taking time to participate in our discussion today. So without further ado, moving forward, we would like to welcome Jan with the Raynaud Association of America. Thank you so much.
And thank you guys. Thank you to everyone for having me. I'm very privileged and honored. And yes, I am in New Jersey. I am in United States. So a lot of the things I'm going to talk about today, we'd have to really go over as far as medication, because we live in different countries. But we'll get to that once we get through my presentation. So again, thank you guys. And let me just turn my screen over. See if I can figure out how to do that. Okay, can you guys see my screen?
Not as yet.
Okay.
I know you said you were having some challenges today with.
No,
Yeah.
I don't know what's going on with my computer, but it's not allowing me to pick up. Let me see. View. Start share. Okay, so I'm not going to hold you guys up. I'm just going to speak.
Okay, that's fine.
Yeah, I apologize. It started.
And that's fine. You can always send us a copy of that. I'll reach out to you and we'll get a copy of the PDF, and then we'll be posting those online anyways, Jen. So please go ahead.
Okay, so I'd like to start briefly about the Raynaud Association and then quickly switch over to the medical aspects of it, because I have a lot of material I want to try and cover within my time limit. So I'm going to speak a little fast. I know there's time for questions later. And I am from New Jersey originally, so we have a habit of speaking fast anyway. So I think you guys just hold on if I go too fast, okay? So Raynaud's has been around for a pretty long time. There was a gentleman by the name of Augusta Gabriel Morris Raynaud. And back in 1862, he was describing a medical condition where the little arteries, little veins and capillaries in the fingers would constrict, and you would see this color change in hands. And it was just considered a medical condition, wasn't given a lot of audience until back in, I had to say, our CEO who started the Raynaud Association back in 1999, she went to the ER with a similar condition, and it took 2 months for her to get diagnosed, but they actually did come up that she had Raynaud's. And very rare, we considered it very rare at the time, which I'm going to get into myths about it. And that's how the organization actually got started. We have a fabulous website. November of every year is our awareness month, where we have contests, we have special articles, we're on the news, and we really try and promote awareness, since there are so many millions of people that have it and they don't even know that they do. We're on social media, we're on Facebook, Twitter, and Pinterest. We have a members are $5, and it gives you access to discounting prices for all things that we have tested ourselves on what can help with Raynaud's. We have a toll-free number, which will be included in the presentation, where you can call and actually speak with Lynn Wonderman, our CEO, and sometimes questions will come down to me depending upon the severity of the Raynaud's. So you can look for us on raynauds.org, and we have a lot of great reviews. We have a quarterly newsletter, which is very, very informative. It takes you through Raynaud's, through all the different seasons of temperature changes, things that would really correlate with what you might be going through. So that being said, I'd like to talk about what Raynaud's is. You know, when I was first diagnosed, I remember I was at work and I was working in a corporate setting, and it was so funny because out of nowhere, my hands just turned purple, and they were purple and they were changing colors. And I was like, oh my God, I don't know what's going on. I've never seen anything like this. So I went to my primary care physician, and he's like, oh, you have Raynaud's. I never heard of anything what Raynaud's was. And I'm in the medical field over 30 years now. So I researched it, and he didn't give me any medicine. He told me to stop smoking, because back in the 80s, people smoked, right? So I stopped smoking, and it didn't go away. And that was what really caused me to start looking at different doctors or different medical educators that could help me find out what was wrong with me. So that leads me to what is Raynaud's? Now, inside our body, we have a very sophisticated system. It's one of 3 systems, and what it is, it's actually called the anatomic nervous system. And in our nervous system, we have, our body is very smart. It has the ability to protect itself, and we call this the flight or fight response. So when you're exposed to danger or something that you find stressful in your body will prepare itself to either fight and increase all these hormones in your body, get excuse me, get flow to your essential organs, get you ready to fight and protect yourself. The other is to flee, fight or flight. I call flight fee, where you just take off and you're not exposed to the to whatever was causing you to have stress. But what happens with people with Raynaud's is they stay in that system. They stay where the body can't go back to dilation of blood vessels. Remember, when you have an attack, everything gets constricted and blood flow goes to the heart and the muscles and the organs, and it takes blood flow away from the extremities. So that's what's actually happening. You're having an exaggerated response to a threat or or something that you see as being dangerous. And that's why we get into the myths. So the first myth, Raynaud's is a rare disease. Okay, it is not a rare disease. In fact, in order for something to be clarified as a rare disease, it has to be less than 200 cases in the United States. Well, we have 15 million to 30 million people in the United States that have Raynaud's, and 1/10 of them are unaware that they have it. Some people, you know, they're very athletic and they go outside and their hands turn red, and there's all different levels of Raynaud's. Well, there's a lot of people that don't know it, and actually 9 out of 10 females have it and they may not know it. And actually those females are usually within the childbearing age. So Raynaud's is not a rare condition. It's known as either primary or secondary, which we're going to get into in just a few minutes. Myth number 2. Just all crazy today with my computer going crazy for me, causing me to, sorry about that, ladies. Raynaud's number 2. Okay. I apologize again. There is no formal test for Raynaud's. Okay, so there is no formal test. However, there are tests that can be used to help diagnose, to help the doctor make the diagnosis. So when I was first diagnosed, the doctor looked underneath my nails for capillary abnormalities. And then they also looked at any changes in how my body responded to cold. And this is one thing about Raynaud's that's very people really need to know is you should try and take a picture of when your hands are in a Raynaud's attack, because you can't control them basically. I mean, you can to some degree, but when attack comes on, unless you can force yourself to have an attack when you're with the doctor can't really see that you're having a Raynaud's attack. That's what you really want to do. You want to take a picture so that he can see your fingers, and then he can properly find ways to diagnose you. So that's the first thing. I'm really into patient advocacy. That's the first thing that you should do. Now, there is a blood test. It's called an anti-nuclear antibody test. And, you know, this is a test. It's not a positive, it's a positive and a negative test, which means it's not qualitative. It's not quantitative. So what that means is if you get an ANA test, it could be positive, but it could be positive for Raynaud's, but it could also be positive for secondary conditions. Like I have scleroderma, okay? That's a secondary, so I have Raynaud's from a secondary condition. Fibromyalgia, lupus, MS, these are all secondary conditions that Raynaud's could become. But the primary condition is why you're having the attacks, even though the secondary condition came through. So we want to keep in mind that the doctor, you may have a positive ANA test, and he needs to do a panel afterwards. I can't stress this enough as a med tech. If the doctor says you have a positive ANA test, ask him to do the whole autoimmune panel. Then you'll really know if it's from a secondary condition or not. And if it doesn't show that it's a secondary condition, don't leave that as being a definite no. I would keep on testing the autoimmune panel at least once or twice a year, just make sure that you are not developing a secondary condition, because a lot of the secondary conditions can be controlled if you diagnose them early. So it's all about diagnosing yourself early so that you can be proactive in your care. The third myth, which is Raynaud's affects only the fingers and the toes, that again is not true. I have Raynaud's on the tip of my nose, like just between my two nostrils. I get a Raynaud's attack here. I have a little ulcer. I get them on my ears, on my tongue. There are people that get Raynaud's attacks on their breast and even their sex organs, believe it or not. So it's not just your hands. It can be other parts of your body that are not, think about it, the things that are away from your heart, right? There's got to be circulation to get to there. Well, if you're having Raynaud's, you're constricting the circulation because you're having that vasoconstriction, and you're causing you to have lack of blood flow to any tissue that could cause you to have loss of oxygen to the tissue, because that's what's happening with Raynaud's attack. The blood vessels are constricting and it's compromising blood flow. So what happens is you can't keep your body in that state for a long period of time. And that's why there is medications, which I'm going to get into, and different ways of changing your lifestyle so that you can control your Raynaud's attacks. So just keep that in mind, that it doesn't have to just affect your fingers and your toes. Myth number 4, Raynaud's sufferers only have poor circulation. So it's so funny because if I run into somebody, I'm like, oh, your hands are so white. She's like, oh, I have poor circulation. I'm like, oh, did you ever get tested for Raynaud's, or did you ever think you might have Raynaud's? And they're like, what's that? Because people automatically think that if they have poor circulation, if their hands or their feet are not colored right with that red, nice blood flowing color, that it's just poor circulation, but it might not be. People could have different fight or flight thresholds. Like for me, I have severe Raynaud's. So if I go into a room that's hot, from hot to cold, I'll have an attack. That's how fast I can have an attack. So it all depends on your thresholds, and you have to find your thresholds so that you can properly manage how you're dressing, what kind of climate you're in, who you're around. I mean, it's all about you keeping yourself warm so that you can help get oxygen to those areas that are being compromised. Myth number 5, Raynaud's is an allergy to the cold. You know, there is a condition called cold urticaria, which you can get, which is like a rash and itchy, and it's not Raynaud's though. Raynaud's is not an allergy. It's not an allergy. The allergy one looks like a skin condition. Just so you know, people may say, I have an allergy to the cold. There's no such thing. Okay, number 6, Raynaud's is seen as a nuisance and not a medical condition. I can tell you that understanding if you have primary or Raynaud's syndrome, which is what you'll do when you go to the doctor and you ask for that special autoimmune screen panel, and then you need to explain it to your family in a way that they can understand. It's all about misunderstanding things, and that's why some people might think you over exaggerate, or there's really nothing wrong with you, but there is something wrong with us, and there is a condition, and we need to explain it so they understand what we're going through. Sometimes Raynaud's attacks can be very painful. Think about it. You have blood flow being compromised to an area that's going to bring pain. People may not understand that when you're having a Raynaud's attack, that you're in pain. You have to tell them. I used to use an analogy, and maybe you guys could come up with your own. how to explain a digital ulcer. So digital ulcer, these little cracks in the fingers, I'm sure you can't really see my hands. I have these little digital ulcers. And when they are painful, I was trying to explain to them, do you ever get a paper cut and it stays on your finger and how annoying and painful that is? That's what this is like, but add lemon to it. Think about adding lemon to a little cut and what the burning would be. That's kind of like how I tried to explain my Raynaud's attacks with my digital ulcers. So if you're having a problem communicating what's going on with your body and what's going on with your in your mind, that you don't feel people are listening or they're not being empathetic, try and explain to them in a way that they can articulate it in their head. And then we want to avoid attacks. I moved to Florida from New Jersey, and it was good, but it was not a solution. Everyone thinks, oh, let me move to New Jersey or let me move out of the cold. Okay, I have to deal with air conditioning and going in and out of stores that are freezing and into 100-degree weather. Our seasons are, our lowest temperatures are in the 40. You can still have a Raynaud's attack then. So if you think moving to a different area might help, it does help a little. Instead of going inside to stop an attack, I might run outside to stop an attack because the heat is so good. So just think about that kind of stuff. If you're thinking about making some major changes on moving, you can handle lifestyle changes with how you dress. Prepared for dressing. If you know you're going to the store, bring mittens, bring a sweater, bring hot packs, bring anything that's going to make your stay in that store comfortable, where you're not going to be wanting to get out of there because you're freezing to death and your fingers are numb. So, and then stress. I know we talked about it with fibromyalgia. I think it's actually the backbone of all of these autoimmune diseases is stress, and how important it is to know your stress factors. Know what stresses you out. Is it your family? Is it your work? It's probably yes to all these things. Is it your kids? Is it your house? Is it your job? I mean, God knows where we get stress from, but we really need to sit down and journal about our stress and think about how we can find a way to try and calm it down. I do a lot of meditation. I do a lot of breathing. I always spend time doing things I like, even if it's 5 to 10 minutes a day, whatever it is. Find ways to reduce your stress. It is the backbone to all of this, I have to tell you, and it's very critical that we understand that and people really acknowledge it. I mean, stress has been around forever and everyone's like, oh, it's okay, you're just stressed. Well, the body's like, okay, it's not okay. Stress is making me get sick, and everybody needs to understand that. You know what I mean? So I had to quit my job. I was in corporate America. I was a scientist. I was traveling the world, and I had to quit my job. The stress was too much, and now I do a lot of volunteering, and I work a little, and it's still stressful, but it's better than what it was. So these are things to consider depending upon how Raynaud's is affecting your quality of life. Think about things that you might want to change. Okay, so I wish I had my slide, but you're going to have to, just to remember myth number 7, the slide, the color changes. Okay, so the normal thing you see is once the body starts to lose oxygen to your fingers, your hands go like a ghostly white. They can even turn black. Black means that you're at a cyanosis, where you're having some tissue death. You want to get out of that state. And then as the blood flow starts to come back, you get this patchy red, white, and blue colors. I get them. You might have milder attacks where you just white for a while, but you'll know it. You can feel it. You can feel that there's something going on with your fingers. You can even have pink fingers. So just get to know what your Raynaud's attacks look like and take pictures when you're having an attack. That's really, really important. I'm going to talk about medications briefly. Some of these I'm not sure if you can get over in your country, but we need to talk about them because they really are great relievers. So the first thing my rheumatologist put me on was Prozac, which is crazy. I'm like, why are you putting me on Prozac when I have Raynaud's? There's that stress factor again, ladies, that stress. What does Prozac do? It helps to release serotonin in your body so that you can relax and be more calm during stressful. So he put me on Prozac. and I couldn't believe it. And he put me on a beta blocker, which is not the best thing right now. I'll tell you why. But these things are the first line of defense. So don't be surprised if you go to your primary care physician and they want to give you Prozac, or they want to give you a vasoconstrictor. So that's where we get to the medications. Calcium channel blockers are one of the medications that are used for Raynaud's. I've been on it for 20 years and they do help. And I'll tell you, I tried to get off that Prozac, and I have to say my Raynaud's attacks came back tenfold. So I'm back on it again. They have different kinds of paste and gels out there, nitroglycerin paste and patches for the ulcers. Erectile dysfunction drugs, believe it or not, they work, ladies. Viagra, as men use it, as that's called, it's called sildenafil for us. SINDENAFIL, sildenafil. It's a Viagra form for women, and it helps with ulcers. There are other drugs out there. There's Cialis. Again, I mentioned antidepressants. You really want to look at ACE inhibitors, but you got to be careful of side effects of these. Like, for example, Vasotec is one of the heart medications that's used, but it actually aggravates blood vessels. So you don't want to take that if you're on Vasotec with another medication that's going to aggravate your blood vessels. So my point is this: there are medications out there. You have to check with your doctor. Some of them are using them off the label. Off label means they're giving you drugs. Like, for example, if you don't have a heart condition, you go on calcium channel blockers. That's really been FDA approved for heart. It hasn't been FDA approved for the hands. Doctors are using it. So be prepared. They might offer you something that's off label. There's also surgery that can be done, which is called the digital sympathectomy. And then there's holistic and natural remedies, not clinically verified, but when I practice medicine on myself, I do holistic and natural medicine. There's a balance between the two. You just have to find out what balance is good for you. The ninth myth is that it's only for cold climates. I already told you guys all about that, how moving, lifestyle changes, it's very individualized. And then the last myth is that you can lose a finger or a toe. You know, those are in rare cases. I have a finger, I lost my finger. See right there? I lost my finger because what happened was I had an ulcer from a Raynaud's attack and I didn't take care of it. And the infection went down to the bone, and that's how I lost my finger. These are rare cases, okay? If you have primary Raynaud's, don't give it any other thought. That's it, it's done. Secondary Raynaud's, you have to worry about. You need to just manage your Raynaud's attacks. And that's really the biggest thing I can say about all this information is you need to know your attacks, when they happen, find ways to reduce them, talk to the doctor about medication, be your own advocate, look outside the box. I go to my doctor, I say, listen, I found this new thing. What do you think about that? You should be able to go to your doctor and talk to him like you could talk to your best friend and tell him, these are the things I have wrong with me. So patient advocacy is key to quality living. And I thank you. I'm sorry if I spoke too fast. I'm really sorry about the presentation, but I will get it to you. And please go in there and look at everything because I might have missed some stuff.
Okay. Thank you so much, Jen. That again, and lots of information. Again, we will get that information. We will have it on our website under the education section. Again, so much information here today. Thank you so much, Jen Nitti, Danielle Hogg, Dr. Leslie Laing, and Jacqueline Fraser. You guys have done an amazing job. I hope you're seeing the comments in the chat. I think everyone who's here today is really appreciating what you brought to this discussion. So many things to learn. I've learned a tremendous amount of information today. And that's why I think it's really important to get these PDFs so we can review it at our own leisure. the recording will also be posted online at Lupus Ontario, so you could go back and listen at your convenience. So again, thank you, everyone. We will take a few minutes. I just don't want to intrude on our guest time. If you're okay staying on for maybe an extra 10, 15 minutes for these questions, Dr. Lan and Danielle and Jan, are you guys all okay? Okay, perfect. I see some thumbs up. We will take a few minutes. Myself and Rupinder, we're going to scroll through the chat and see maybe something that was done earlier. We will not try to miss anything, but if we do, I have access to the chat after the webinar is finished, so I can also go back, and if there's something we missed, I'll be able to contact our guest speakers and they could maybe address it, and then I could forward that information to you. So we're just going to go back. Just be patient with us as we scroll back. Rupinder, I will ask you to take away maybe the first question. And
Sure.
There's a lot of comments. We won't go through the comments at this time, but like again, I said for our guest speakers, lots of comments. I think a lot of appreciation for today. So we'll just take a few minutes and try and get through as much of the chat in the next 10, 15 minutes.
Thank you, Sandra. So thank you everyone for your amazing presentations. The first question that I can see comes from Michelle, who mentioned that she is recovering after a minor knee surgery and she has had arthritis and is in very severe pain in her knees. I'm not sure if that was a question or just you're sharing, but any recommendations, maybe Danielle or anyone else could jump in? It was arthroscopic surgery.
So we don't do any post-surgical care that's done at the hospitals. So I can't really comment on, we kind of see people prior to that to get them ready for surgery. And people who have recovered from surgery who maybe still have some joint pain that we can address afterwards.
Thank you. I have another question here, if you about Sjogren's. Is a positive Sjogren's antibody combined with dry eyes enough to diagnose?
Yes, hi. Just key on pronunciation, it's like Sjogren's.
Sjogren's.
Yes, yeah. So apologies to the Swedish where it would be sort of Sjogren's, but anyway, Sjogren's.
Thank you.
So the latest criteria that was published, it's called 2016, has a weight scale of determining what is primary Sjogren's. And Jan, thank you for mentioning primary versus secondary. You see, this is one of the problems in that terminology, because primary Sjogren's means you only have Sjogren's. Secondary means you have Sjogren's and something else. So it's an unfortunate set of terms. But having said that, so the new weight scale gives a weight of 3 if you have a positive antibody test. And if you're looking specifically for Sjogren's, it would be a positive anti-SSA or anti-Rho.
Right.
We found that too many people did not have the law, which was the SSB antigen. So we really only look at the SSA. And so that if you have a positive test, you get a weight of 3. Then with respect to the eye tests, so dry eye, I'm basing that on, they put a piece of litmus paper in your eye and measure how much tear substance you can produce in a certain amount of time. And again, if it's less than a certain amount, you get a score of 1. So right there, that would give you a score of 4. And to have a minimal scale, sorry, a minimum weight of 4 indicates that you have primary Sjogren's. Now, that's not even looking at the mouth, how much saliva you can produce. It's not looking at the staining of the eye, whether you have irregularities in the eye surface. It's not even taking into account the lip biopsy to see if you have a focus score. So if you had those, then you probably have primary Sjogren's.
Okay. We have another question for you, Dr. Laing, while
Oh,
you're there.
Sure.
Ophthalmologist has not said Sjogren's,
Sjogren's, yeah.
but says I still have dry eyes even after 9 months of drops 4 times daily. So wondering if your website has a handout on any ways to help dry eyes.
Yes, certainly in our brochure, which I should grab in a minute. There's a panel on dry eyes, but if you wish to contact our site, as I say, we were just updating the website now, but there is information on dry eyes. That was actually a session that we had in one of our town halls that was sponsored by, well, it was actually an eye care company who sponsored it. So it was a little different in format than our usual town halls, but there will be another one in our traditional format where patients can chat in or call in to us specifically, but check on the website and in our new brochure for the dry eyes, because if you can get a brochure to your ophthalmologist, it could easily be Sjogren's.
Can I interject for just a second?
Sure. Yes, Jan. Yeah.
So I do not have Sjogren's, but at one time, because you can have Sjogren's with scleroderma, I went to an ophthalmologist, and there is a surgery that I was going to get, which I didn't, where they go and they actually can open up the little areas where your eye fluid comes in and lubricates. They can actually open those little tear ducts there and help get fluid in. But I never went through with it. But I don't know how, if that's available in Canada or not. But there is a surgery out here.
Yes, there is that too. Yeah, but I think you want to try everything else before that. Yeah. Yeah. Jan, you're making me so cold. I'm sitting here and you're in sleeveless.
I live in Florida and it's 75 degrees here.
Oh.
And I got the heater on, believe it or not.
Okay, thank you, Dr. Laing.
Okay.
I'm not sure if anyone has the answer to this, but if you do, you can jump in. What is a pro-social assessment, as one of our participants has one scheduled this week? Does anyone know? Oh, no, not psychosocial. Sorry, I misread it. Psychosocial assessment.
Okay, what I'll do is I will make a note of that question and I will see if I could get some information, hopefully before Tuesday for you. Maybe do a little bit of send out a quick email and see if anyone else in our organization is familiar with that terminology. Okay.
I believe it's done, I think our social workers do psychosocial assessments, so they just look at, what social supports you have,
okay,
what coping strategies you have in place. That's what comes to mind when I hear that term.
Okay, thank you, Danielle. Okay, that kind of makes sense. So thank you for that. Okay. Is there a list of dentists and eye doctors in Durham region that specialize in Sjogren's? I think, Dr. Laing, you said there was a information panel that gives you all the doctors and stuff in the areas, right? I think that was in your earlier presentation.
That's right. And it's you have a great group in Durham with Kathy Carvonen, who's the support group leader. It's funny, so I'm downtown Toronto and I see quite a few of your group members. So if you're having trouble, often what I'm suggesting is that they might go to their general dentist in your area, but for the dry mouth part, come to see me. I've got some ways of decreasing the decay, which is quite phenomenal. The only thing I've been able to find, and it's working like a charm, but certainly, yes, you can contact us for both general dentists as well as ophthalmologists or other like rheumatologists as well.
Okay, perfect. Thank you.
And Kathy just posted that a psychosocial assessment is an evaluation of an individual's mental health and social well-being. It assesses self-perception and individuals' ability to function in the community. The psychosocial assessment helps the nurse determine if the patient is in mental health or a mental illness state.
Okay. All right.
Can I just go back to the dentist there again? This is Jan. And you know, I'm in the United States, so I can't recommend a dentist, but I can tell you that what I do is I get a cleaning every 3 months. And the reason I do that is because when you have dry mouth, because I get dry mouth, even though I have a lot of saliva when I talk, the bacteria stays in the teeth, in the gums, and you're not constantly cleansing your teeth as well if you don't have the saliva. So my dentist and I increase my visits when I get a cleaning and everything. And that has made a huge difference for me in my mouth being so dry. I don't know why, but it helps. So just a thought.
Yeah, you're absolutely right. And there's also, okay, you hit the nail on the head with the antibacterial therapy. So not only will cleaning do that, but there is now a material that I've done research on called silver diamine fluoride, SDF, and it kills the bacteria. Remember our good old silver fillings? They're still in our mouths, right? But the white ones aren't. And the silver kills the bacteria. I could go on for an hour about that, but if you want any more information, please contact me directly, leslielang.sjogrens@gmail.com. Be glad to answer that. Inexpensive, changes the whole world of dentistry.
Great. Well, I think, Rupinder, can you just confirm? I think we've actually come to the end of all the questions that was there.
That's right.
And it looks like that is perfect time. We did go a little bit over time, but Lupus Ontario, appreciate you hanging in because there was just so much important information. Again, I will be following up with our special guests today. They did an awesome job. We have learned so much. There's so much more I think we can do as organization collaborating together, as we can see. Any one of these presentations could really refer to any one of these conditions, including lupus. So thank you so much, everyone. Linda, I don't know if you have a closing word you'd like to address before we sign off today.
Well, I'd just like to say thank you as well. This was an amazing presentation. I learned so much from all of our speakers. I know that Lupus Ontario gets questions time to time about some of these conditions. And the fact that now we have a good understanding of where to find the resources and the right people to answer the questions, that's very much appreciated. So thank you, everyone. I think we'll be following up with some of the organizations just to see other ways we might be able to work together. So thanks, everyone.
Okay, thank you, everyone. Have a great Saturday afternoon with the rest of it. We appreciate you giving us your morning and early afternoon. Thank you, Jan, for giving up part of your Thanksgiving weekend. Dr. Leslie Laing, Danielle Hogg, Jacqueline Fraser, thank you so much. Have a great day, and I will be in touch with everyone. And for our guests who are online today, please go to Lupus Ontario. I would say next week, the latter part of next week into the early following week, and we should have all this information posted online so you could use it for definitely future reference. Again, thank you so much. Have a great day. Thank you, Rupinder. Thank you, Martina, for assisting with this today. Thank you, everyone. Thanks, Linda.
Bye.
Bye-bye.
Bye.